Hi, this is Elliot Fishman, and welcome to part 2 of our evaluation of the incidental adrenal mass and the things we're thinking about as we enter 2026. I showed you this slide as the last slide, and this was an interesting article. It asked a very simple question. What would you recommend for this incidental 1.7 centimeter right adrenal nodule measuring over 10 Hounsfield units on contrast-enhanced CT in a patient with no history of cancer? Now, of course, statistically, this is surely going to be a benign lesion, but it's over 10 Hounsfield units, so you really can't say what's going on. So you can see the selection. 6 to 12 months in MR, 6 to 12 months of CT, immediate MR protocol, immediate adrenal CT protocol, likely benign adenoma, no further workup is necessary. So you can see the most important thing is the significant variability among radiologists. Now, what you could do is, of course, you can say, let's follow it. But since they want a decision now, typically what you could do is simply bring the patient back and do a non-contrast CT. That may give you the answer because, the lesion may have simply enhanced. Like I showed you before, lesions can go from 0 to 60 or 70 because in this case, there was only a contrast scan. That may be the easiest thing to do and may solve all the problems. Of course, if the lesion measured, say, 25 Hounsfield units on non-contrast scans, then you may need to do the full sequence to make certain you're dealing with a good washout of an adrenal lesion. But again, you can see there's lots of variability, which is not a good thing in practice. Majority of respondents either rarely or never recommend hormonal evaluation or adrenal evaluation with consultation. Now, again, I mentioned that in Europe, a lot more is placed on getting endocrine consultations. One of the challenges, of course, is if you speak to your endocrinologist at the hospital, they're gung-ho about getting follow-ups. But then if you ask who's going to see the patient, they know they're all overworked, and there's not enough people who are going to see every patient if you start getting all of these lab value studies. So it may be a thing to consider, but it may be very, very difficult. The ACR white paper advises consideration for biochemical evaluation for adenomas or incidentalomas, as hyperfunction may not be clinically evident. So it's really a challenge. We tend to stick with looking at size. Europe really wants to exclude hyperfunction. So again, if you want to be super conservative, you could get a battery of adrenal lab values. Now let's look at some of the benign lesions which we can easily diagnose where we have no problem. One is an adrenal cyst. It's water density, a thin wall that does not enhance, and the wall may occasionally calcify. But it's benign looking. Most patients with adrenal cysts are asymptomatic. 10% of patients may have symptoms. Now, the thing about adrenal cysts is they can be very large, and any lesion that becomes really large can be symptomatic just by mass effect. In this article, the average cyst size ranged between 4.7 and 9.6, and not surprisingly, larger cysts were more common in younger patients, and mass effect increased with the size of the cyst. We, again, in this article by Chung, again made the point, a key feature of adrenal cysts is lack of enhancement, water density well defined. Cystic lesions are not necessarily only cysts. You can have cystic metastasis, you can have cystic pheochromocytomas, but in those cases the walls are thick, they're irregular, and the lesion enhances. That's not what you're going to see with simple cysts. Here's an example, non-contrast and arterial phase, water density well defined. The attenuation of that lesion was about 15 Hounsfield units. Most will be under 20. Here it is on the coronal view. Again, well defined, no wall thickening, no nodularity, no real enhancement. Again, this article by Kallisdorf, in the absence of symptoms or functionality, the best management for adrenal cysts is not clear. When a cyst is accidentally discovered and with clear benign imaging characteristics, whether the patient should undergo follow-up for detection of growth is also not clear. So you can see that you can recognize cysts, but the question is, what should you do about them? Again, cysts do not become malignant. That's not really the issue. But cysts can get larger and then cause symptomatic problems. This article was from Hopkins, looking at all of the cysts that were resected and trying to come to some conclusion. The study demonstrated a size threshold of 10 centimeters, below which asymptomatic simple cysts can be observed. If lesions are over 10 centimeters, they tend to keep growing and it's best to remove them. Large simple cysts, those over 10 cm, tend to grow more rapidly than smaller cysts and may be considered for resection. Simple cysts under 10 centimeters typically may remain stable and can be followed. So again, this is not a perfect set of rules, but something that can be very valuable. Now, cysts can calcify. This was an endothelial cyst. I have to admit, when I see a cystic lesion with dense calcification, I'm thinking about an old hematoma, but whether it's a cyst that calcifies or an old hematoma that calcifies, it's a benign lesion. Now, another benign lesion, which usually you can make the diagnosis of myelolipomas. They're benign, non-functioning tumors, more common in older patients, and are composed typically of fat cells and hemopoietic tissue. They also may have calcifications. Interestingly, the cases with the least fat tend to have more calcifications, and the calcifications are often punctate in appearance. Size range is variable. Some myelolipomas contain macroscopic fat, which replaces the entire gland, with a range of -20 to -70 or 80 Hounsfield units. Others contain minimal fat, and those could be more challenging. In theory, adrenal cortical carcinomas can have fat, and in theory, pheochromocytomas can also have fat. But the issue is when you have a pheo, the lesion is so vascular, the fat is just a tiny component and it's not important. With ACCs, the ones that I see that have had fat are large masses, very aggressive, extensive neovascularity. You're not confusing them with a simple, leave alone adrenal myelolipoma. Now, myelolipomas, the one issue with them is they can bleed. The typical rule is over 5 centimeters, they're resected because those are more prone to bleeding. Sometimes people look at the vascularity in terms of AV shunting, but size tends to be the rule of the day. Patients can have pain and discomfort. That's usually because the lesions do indeed bleed. So a spectrum. Right adrenal, 2 centimeter lesion, all fat, myelolipoma. 6 centimeter right adrenal lesion, a little bit of whiskering, which probably is a sequela of an old bleed, but based on size, recommendation would be to remove it. Another lesion with some stranding, but essentially all fat, no difficulty in diagnosis, is that left adrenal myelolipoma. Here's the ones which are harder. There's some gross fat, but also punctate calcifications. The majority of the lesion is soft tissue. But to me, when I see punctate calcification and those globs of fat, it's a perfect diagnosis for adrenal myelolipoma. And here it is again in the axial and coronal display. Very nicely shown. Now, here's a large myelolipoma. And again, the haziness means bleeding. When you see a lesion like this, it's a benign lesion. It's a myelolipoma, but because of the size and the fact it's previously bled, it's going to be more likely to bleed and you'll schedule surgery. You'll do surgery. You will not do an open procedure. You do a laparoscopic procedure. Remember, laparoscopic surgery for adrenal, you're in and out of the hospital in a day or so. Open surgery, you're in the hospital for more than a week and have severe pain in the post-operative period. So again, we love to do it. And again, by knowing it's benign, it's easy to make the diagnosis. This is one of the larger AMLs I've seen. In fact, when they get very large, you can imagine why you might wonder, am I dealing with a retroperitoneal liposarcoma? But this was a huge mass. You could even think about a lipoma of the liver. You could think about a lipoma or AML of the kidney. But this was nearly a 20-centimeter AML of the adrenal, which was resected. Now, another benign lesion is adrenal hemorrhage. Now, of course, malignancies can bleed, theos can bleed, so not everything that bleeds is benign. The most common cause of bleeding is going to be trauma. Usually it's in patients with liver injury or other organ injuries, and it's more common in the right than the left adrenal. Typically high attenuation on non-contrast scans. Can be unilateral or bilateral. Bilateral is more common in patients who are on anticoagulant therapy like Coumadin. Bilateral adrenal hemorrhage is problematic because patients could go into Addisonian crisis. With unilateral bleeds, patients are typically treated conservatively if you know the reason for the bleed. Obviously, if you have a big mass, as I'll show you with bleeding, you worry about an underlying tumor. And bleeding is more common in females. Again, bilateral is what gives you adrenal insufficiency. And what's challenging about Addisonian crisis is that its presentation is hard because it could present like an acute abdomen, myocardial infarction, or even sepsis. So some of the things I mentioned already, but I'll repeat. Underlying tumor, particularly in larger bleeds. Coumadin, more common, will be bilateral. Again, you'll worry about Addisonian crisis. Trauma, more common in the right adrenal. Infection, hypercoagulability states, and stress. The most common adrenal masses with hemorrhage, pheo is number 1, then metastasis, especially renal cell, adrenal cortical carcinoma, myelolipoma, and adenoma. This was an article that was written regarding traumatic adrenal injury, talking about how an adrenal hemorrhage is oval in the range of about 3 centimeters, stranding around the lesion. But the same description for trauma to the adrenal can be seen in almost any case of adrenal hemorrhage, particularly when it's cases like anticoagulant therapy. Here's a nice example: bilateral adrenal lesions, oval, low density, relatively speaking, but it's hemorrhage, and stranding around the lesion. Again, the stranding is indeed very helpful, and this is a very nice case of bilateral adrenal hemorrhage. Here was a case where you would consider maybe a carcinoma. This was resected because it doesn't look like a benign lesion. It's large. Could it be a pheo, but it's not very vascular? Could it be an ACC? Could it be a MET? There's no known primary. But this was removed and was simply a large hematoma. There was no underlying malignancy present. When you have a lesion like this with rim calcification, then I'm really thinking about hematoma, chronic hematoma, and it's a good leave-alone lesion typically. And here it is again on the coronal view. So again, when you start seeing really coarse calcifications, almost circumferential, I've made this comment before, this is the appearance of hemorrhage, be it a cystic lesion in the kidney, the liver, the spleen, or the adrenal gland. Very nicely shown. Now, in this article by Chung, there are no established guidelines for following a mass after resolution of hemorrhage. So here's the situation. You see a big mass that bled. It could be a benign lesion or it could be malignant. but you're not sure. Of course, you can go in and do an adrenalectomy, but maybe it's benign. Maybe you don't have to. What they recommend is to wait 6 to 12 weeks after resolution of the hemorrhage or the initial presentation of the hemorrhage, and then do the CT scan for further evaluation or do an MR. The concern is if you wait less than 6 or 8 weeks even, that the hemorrhage will obscure the underlying tumor. Now, sometimes tumors can rupture and then you're not going to see them anyway, but the key thing is, if you see hemorrhage today, don't repeat the study tomorrow if your concern is looking for a mass, because you're typically not going to be successful. Hemorrhage is a rare complication. Pheo is the most common primary tumor to bleed. Although the underlying mechanism with hemorrhage is unknown in pheochromocytomas, some theories suggest increased intracapsular pressure from trauma, a rapidly enlarging tumor that outgrows its blood supply, and vasodilatation and interstitial hemorrhage caused by the use of antihypertensive medications. Again, pheochromocytomas are a challenging lesion. We often think of small pheos that are vascular and patients hypertensive, easy diagnosis, but pheos can bleed as their presentation, they can be very large, and they're not always very vascular. Now, again, going with the hematoma, large lesion, right adrenal, dense calcification, that's an old hematoma. Now, what about malignant tumors? Now, when we talk about malignant tumors, primary adrenal cortical carcinoma is rare, but it's the one we think about. Probably more frequently we'll see metastasis, particularly if you're at an oncology center. Pheochromocytomas, 10% are malignant. Lymphoma, involvement of the adrenal, not uncommon, but primary lymphoma is somewhat rare. And then neuroblastoma, usually in pediatric patients, but can also be in adult patients. So let me at least talk about ACCs a little bit. I mentioned before, and I'll remind everyone, Cushing's is the classic presentation. Okay? In females, virilization resulting from excess androgens may accompany signs of excess cortisol. A small percent of male patients present with signs of estrogen excess, such as gynecomastia, breast tenderness, decreased libido, and testicular atrophy. So the ACCs can be challenging, but can be very symptomatic. A majority of ACCs, of course, are going to be incidental. They're large, 70% larger than 7 centimeters. The smaller ones are the ones that have hyperfunction, because it's that hyperfunction that makes them present earlier. An attenuation value of more than 10 Hounsfield units on non-contrast CT has a high sensitivity for detecting malignancy, but a low specificity. And we know that from before. Now, when you think about adrenal carcinoma, in your mind, a large adrenal mass, it's enhancing, it's irregular, it's necrotic, maybe there's some calcification, but things that can look like ACC, pheos, large adenomas, particularly when they're vascular, and I showed you an example before, metastasis, particularly from hepatoma, particularly from renal cell carcinoma or melanoma, adrenal lymphoma, ganglioneuroma or ganglioneuroblastoma, adrenal hemorrhage, and the occasional case of a very vascular adrenal hemangioma with really prominent vascularity. So let's do this. Why don't we stop here? Let's come back and let's look at a number of malignant cases, starting with primary adrenal cortical carcinoma, and I'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.